how-to guide for residents, vacuum-assisted vaginal deliveries. By the end of this video, you should understand the following regarding vacuum-assisted deliveries: indications, contraindications, structure of the device, how to place the vacuum, how to use the vacuum for the actual delivery of the fetal head, and complications. There are a number of indications for a vacuum-assisted delivery. These include a prolonged second stage, a non-reassuring fetal heart tracing, and shortening of the second stage due to maternal exhaustion or for maternal benefit, such as in situations of maternal cardiac disorders. A prolonged second stage is defined as greater than 3 hours of pushing for a nulliparous woman with anesthesia, or greater than 2 hours without, and greater than 2 hours of pushing for a multiparous woman with anesthesia, or greater than 1 hour without. It is also important to know the various contraindications to vacuum-assisted deliveries. These most commonly include less than 34 weeks gestation and less than 2,500 grams. Additional contraindications include fetal demineralizing disorders, such as osteogenesis imperfecta, fetal bleeding disorders, prior scalp pH sampling, however this is not routinely done in the U.S., and face presentation. While not an absolute contraindication, fetal macrosomia should make one pause prior to attempting a vacuum delivery. The maternal risks associated with vacuum deliveries include pain. However, there is no good evidence that postpartum pain is worse after a vacuum-assisted delivery than a normal vaginal delivery. Lacerations. There is a higher rate of 3rd and 4th degree tears, as well as vaginal wall and cervical lacerations, and incontinence. However, there is nothing to prove that long-term dysfunction is worse after a vacuum-assisted delivery compared with a normal spontaneous vaginal delivery. Neonatal risks, which should be discussed with the patient, include cephalohematoma, subgaleal hematomas, retinal hemorrhage, neonatal jaundice, shoulder dystocia, and scalp lacerations. Before applying the vacuum, there are a number of things you must know. You must confirm the fetal station is at least +2 and confirm the fetal position. You must confirm complete dilation and ruptured membranes. You must confirm that you do not suspect any cephalopelvic disproportion, and you must review the estimated fetal weight. Now let's take a look at the vacuum more closely. The vacuum has a cup that is applied to the fetal head, a stem, a pump, and a traction indicator that allows you to know that the suction is sufficient. And there is also a release button. There are various types of vacuums. There are ones with metal cups that are used less frequently, and ones with non-metal cups. The non-metal cups can be soft or rigid. The soft ones are bell-shaped, and the rigid are flatter. Now let's discuss actual placement of the vacuum. The vacuum will be placed on the fetal scalp. You want to ensure you are placing the vacuum on the flexion point. The flexion point is located on the sagittal suture, 3 centimeters in front of the posterior fontanelle, and 6 centimeters from the anterior fontanelle. Ensuring that the vacuum is placed on the flexion point allows you to maximize traction, decrease the likelihood of the vacuum popping off, and aid in the flexion of the head to allow the smallest diameter of the fetal head to present first. If placed incorrectly, you risk cervical spine extension, and if the baby is slightly asynclitic, placing the vacuum asymmetric to the sagittal suture can actually worsen the asynclicity. Now I'm going to demonstrate actual placement of the vacuum. First, I'm going to feel for fetal station, confirming it's at least +2, and then I will confirm fetal position so I know where to accurately place the vacuum. I will then grab my vacuum and place it on the flexion point, feeling around to make sure no vaginal tissue is entrapped. I will then pump up the vacuum to adequate suction indicated by the green line, and again feel that no vaginal tissue is caught. The non-dominant hand will be placed in the vagina with your thumb on the cup and the other fingers on the head. Keep your non-dominant hand in this position while pulling. This will allow you to feel if the cup is starting to separate and allow you to feel the descent of the head. You will pull as mom pushes for the greatest benefit. The angle of traction will initially be downward as baby goes under the pubic symphysis. Gradually, the vector will become more upward as the head is delivered. You should notice progressive descent with each pull. Once the fetal head is delivered, release the vacuum and proceed with the normal steps of a vaginal delivery. The failure rate of vacuum deliveries is approximately 14%. Failure is more common with maternal obesity and diabetes, African Americans, those over 42 weeks gestation, fetuses weighing greater than 4,000 grams, and those in OP position. Success is improved, though, with an epidural. Make sure you choose the right patient.